Dear chairpersons, dear colleagues, it's a great pleasure to participate in this meeting. I'm Dr. Barsara from Koç University Istanbul and ART Fertility Clinics in Dubai. My talk is about assisted reproductive technology for women with endometriosis. These are my disclosures, none of which are relevant. We've always thought endometriosis is associated with infertility. However, association does not necessarily mean causation, and we don't exactly know how endometriosis affects fertility. This is a nice review by Edgardo Somigliano and colleagues published in 2018, where they review potential mechanisms by which endometriosis may affect fertility, and except for the pelvic adhesions caused by this fibrotic disease, we do not know how it may affect fertility. There are a lot of theories like endometriomas affecting oocyte development or oocyte quality, the presence of adenomyosis affecting implantation potential, increasing risk of miscarriages, and the inflammatory condition in the abdomen affecting multiple steps for a healthy pregnancy. But these are all theories. Now, in the upcoming slides, I'll review ART data to see if these theories hold in clinical practice. The first study I would like to share is from RMA, New Jersey, where they compared blastocyst diploid rates between women with and without endometriosis. As you can see in the graphs broken down into age categories, the most important determinant of aneuploidy, women with endometriosis, light blue bars, had similar aneuploidy rates with women without endometriosis in any age category. So if an oocyte makes it to a blastocyst, that blastocyst is similarly likely to be diploid, regardless of endometriosis status of the patient. This study wouldn't capture if the oocytes from patients with endometriosis have a lower chance of blastulation, which is answered by the next study to some extent. This is another US study where the authors compared IVF outcomes between patients with endometriosis here and couples who underwent IVF because of a male factor, where you can assume to some extent the female partner is healthy. And even better, a second control group comprised patients undergoing IVF for diagnosis of monogenic diseases in the embryo. So these people are not necessarily infertile. They are fertile. They are usually diagnosed with having an affected child formerly. What you see, even though the numbers are not that big, similarly aged women matched for that, similar AMH level, they had similar number of oocytes collected and similar numbers of blastocysts, suggesting blastulation rate is similar, regardless of endometriosis status. And when they further investigated the implantation and live birth potential of these euploid blastocysts from patients with endometriosis, they did similarly well with couples with male factor or couples undergoing IVF for diagnosis of monogenic disease, similar positive pregnancy test rate, similar clinical pregnancy rate, similar pregnancy loss rate, and similar live birth rates. And as you can see, with the blue bars representing endometriosis patients, the trends favored endometriosis. So data so far does not suggest endometriosis affects oocyte developmental potential or the implantation and live birth rate potential of euploid embryos, regardless of endometriosis status. This is a retrospective analysis of the SAT database. The numbers are huge as it's a national database. What they did, the authors did, they compared embryo transfer outcomes between cycles where the only indication was registered as endometriosis where endometriosis was one of the indications for the cycle, and unexplained infertility, tubal factor as indications, and all other diagnoses except for endometriosis, unexplained infertility, and tubal factor. What you can see here is blastocyst transfer rates are similar, implantation rates seem to be similar, even slightly favoring endometriosis alone, and live birth rates again look similar, the highest number being in endometriosis patients. And when the results are broken down for fresh and frozen embryo transfers, overall, it looks same, conclusions. And when they did adjusted analysis for important confounders like BMI, smoking history, race, number of prior cycles, year of treatments, and other factors, endometriosis only compared to unexplained tubal or other diagnosis in the adjusted analysis on the right sides. Okay. You see, oocyte yield was slightly lower with endometriosis, especially understandable if there was an endometrioma. Blastocyst transfer rates are similar or slightly lower than tubal factor here, but again, we need to look at the absolute numbers. The live birth rates are similar or even higher with endometriosis in fresh transfer cycles as well as frozen transfer cycles, as you can see here, and as you can see the trend in these two comparisons. So overall, the studies I've shown speak against a detrimental effect of endometriosis on ART outcome in these regards. Number of oocytes collected can be slightly lower, however, fertilization rates are similar, aneuploidy rates are similar, pregnancy loss rates are similar, live birth rates after a fresh or frozen embryo transfer are similar, or even maybe slightly better in patients with endometriosis, speaking against an obvious adverse effect of endometriosis on ART outcomes. I'd like to show one additional study, which was more recently published than the review, including 13,000 donor oocyte cycles. I apologize, my image blocks the view, but what this study showed in the adjusted analysis, oocyte recipients with endometriosis did not perform worse than oocyte recipients without endometriosis. So endometriosis per se does not seem to affect receptivity or the course of pregnancy in this regard. So this is the IVF data. Then a common question is, should we do a diagnostic laparoscopy and try to ablate minimal mild endometriotic foci before an IVF cycle? The reason I'm showing this cohort review is there are multiple editions of it. In some editions it says it's harmful, in some editions it says it's not worth it, etc. Here, in the 2014 version, it looked like prior ablation was useful to improve IVF outcomes, but the famous Italian study was excluded, and the second study, next to the Canadian study, was just an abstract. If you look at, on the other hand, the combination of pooled analysis of Canadian and Italian studies, the difference is not significant. Okay. So what I'm trying to say here, if you include all three, again the difference is not significant. You see, meta-analysis depends on what you include, what you exclude, and how you do the analysis. So it's controversial, but there's no obvious benefit of prior ablation of minimal mild endometriosis before an IVF cycle. There's this other retrospective study suggesting it may be effective, but whichever opinion you subscribe to, you see as the number of diagnostic laparoscopies you would need to do to have one additional pregnancy with IVF due to ablation of minimal mild endometriosis. The number would depend on the underlying prevalence of endometriosis in your unexplained infertility population. I mean, there's no other way, until recently, to diagnose minimal mild endometriosis without a laparoscopy in a normal appearing woman. And if the incidence is as high as, the prevalence is as high as 50%, you would need to do 17 diagnostic laparoscopies to have one additional pregnancy. However, at more reasonable figures, if it's 10 or 30%, the number goes up to 26 to 75 surgeries to have one additional pregnancy, and these are just point estimates. If you look at the upper bounds of confidence intervals, the numbers can be huge. So I agree with the most recent ESHRE endometriosis guideline, where I also participated in its preparation. It's not recommended, actually it's recommended against doing a diagnostic laparoscopy prior to an IVF cycle, just for the sole purpose of maybe identifying minimal mild endometriosis and then ablating it to improve IVF outcomes. And former studies from England, which we can't reproduce nowadays for ethical reasons, if you see minimal mild endometriosis in a patient, and if you repeat diagnostic laparoscopy in 6 months without treatment, you would see in almost half of them spontaneous regression of the lesion. So the additional benefit of laparoscopy is further controversial, and beware, most laparoscopy complications occur during the entry into the abdomen, the blind entry into the abdomen. So diagnostic laparoscopy should not be taken lightly, and it's not indicated to improve IVF outcomes. How about advanced endometriosis? This is a retrospective study from Horace Roman's team. It's a propensity score match, relatively large study, including women who had colorectal endometriosis. And what you're suggested is if surgery preceded ART, you would have faster pregnancies and a higher cumulative live birth rate, as opposed to doing IVF as the first choice. However, surgical studies should be considered more difficult to generalize for multiple reasons. There are patient selection in the first place, and then surgical competency. Okay, so not necessarily everybody will have similar results as this very experienced team, and the propensity score match study does never replace an RCT. Okay, and even in Horace Roman's series or Arnold series, the complication rate of colorectal surgery for endometriosis or deep infiltrating endometriosis surgery could be as high as like 10-15%, including fistula, etc., delaying further treatment, further attempts at pregnancy. So without further strong evidence, it doesn't make sense, at least to me, to prioritize surgery in the absence of other indications to improve ART outcomes. Now, the next subject is endometriomas, which we often see in patients with endometriosis. This is the HRU update from almost 10 years ago. What it shows, when there's an endometrioma in situ compared to a patient without any endometriomas, similarly, live birth, clinical pregnancy loss rates are similar, only the cycle cancellation rates are higher in the presence of endometrioma, which is understandable. Endometrioma decreases ovarian reserve, makes oocyte collection, may make it more challenging, but if you collect the oocytes, the developmental potential is the same, the cycle outcome is the same, so it doesn't suggest removal of endometriomas are required before an IVF cycle. And here is a more recent meta-analysis, this time directly looking at the effect of surgery, comparing women who underwent surgery for endometrioma excision versus who had their endometriomas in situ without surgery. Live birth rates are similar, clinical pregnancy rates are similar, so removal does not improve IVF outcomes, further lending support and actually informing the extra recommendation for avoiding endometrioma excision in the absence of another indication, just to improve IVF outcomes. Endometrioma is still a problem. What we have shown before, endometrioma decreases ovarian reserve in age-matched women, and ovarian reserve declines even faster, even within 6 months. And endometriomas may render collection more difficult, even though it doesn't look statistically significant in this small sample published by Edgardo Sobriliano's team. But if you can reach the follicles, as you can see, oocytes retrieved per grown follicle, like 40 millimeters or more, the rate is the same. But overall, probably because of excess problems, you may end up with lower number of oocytes. So that shows we need to individualize the decision to remove endometriomas prior to ART if they render oocyte collection extremely difficult or risky. Then surgery may make sense, but it should be a case-by-case decision. So when we did a study on complications of oocyte retrieval procedures, what we've realized, actually all infectious complications were almost exclusively reported in patients with endometriosis. So the chronic inflammatory condition, possibly puncturing endometriomas, etc., increase the risk of pelvic abscess and infection. And I would say, if you look at the studies, or the original earlier studies, iodine cleaning of the vagina prior to egg collection, the evidence suggesting that it may be harmful to the oocyte is not really strong. And this Taiwanese study suggests if you clean the vagina with iodine and possibly with another antiseptic, the risk of abscess may be decreased. So this is for years what I've been doing in my practice for years. If a patient has endometrioma, I clean the vagina with iodine and then wash it with saline multiple times and then do the egg collection to decrease the risk of infections. I think it makes sense. That's why I do it. And now regarding stimulation, should we do a prolonged suppression? I'll just cut to the chase, long story short. Overall data does not suggest prolonged suppression before ovarian stimulation improves IVF outcomes. Whether you do it with a progestin or GnRH analog, actually this study below suggests progestin, long-term progestin exposure may even decrease your clinical outcomes. But we need more data to see it. But prolonged suppression aside, for the pituitary suppression during the stimulation cycle, you can use GnRH analogs or progestin primed ovarian stimulation. And this large Chinese study looks at, with different progestins for PPOS have different effects. Actually, again, when the numbers are big, the differences may look significant, but overall, I don't see a clinically relevant difference. So if you're not intending a fresh embryo transfer in a patient with endometriosis, and you opt to do a PPOS cycle, probably you can use any progestin. If you want to be as evidence-based as possible, you can prefer MPA over the other progestins in context, but I think it's just one coincidental finding here. Next question is whether ovarian stimulation and increased steroid levels during stimulation adversely affect the endometriosis status of the patient. Does it increase pain scores? Does it increase recurrence rates if she had treatment before? No, it doesn't, based on some evidence. And it makes sense because endometriosis is a chronic disease. Yes, it feeds on estrogen. However, a short rise in estrogen just for like 7 to 10 days or maybe 12 to 14 days, I wouldn't expect it to change the course of the disease. And while stimulation may cause a slight but significant change in the size of endometriomas as measured with its volume, what we've observed in this study, they rapidly return to shrink to their original sizes, so it's not a worry again, and it doesn't justify surgical intervention for endometriomas or to avoid stimulation in these patients. So overall, I would conclude endometriosis does not affect euploid rates or implantation rates of euploid embryos, and the data does not suggest it affects blasculation rates or embryo developmental potential. And as such, surgical treatment of endometriosis is not routinely required prior to ART for endometriosis associated with fertility, unless there's other indication. We don't need prolonged suppression before ovarian stimulation. Any pituitary suppression protocol can be chosen. And we need trials comparing outcomes of fresh or frozen embryo transfers in patients with endometriosis. And except for risk of infection, ovarian stimulation does not hamper the course of endometriosis. So thank you for your attention. I'm happy to answer any questions.